Hello, everyone. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. Thank you for joining us for the sixth in our series of briefings on preventing and managing COVID-19 in the workplace. We appreciate your ongoing participation. This session is being recorded and will be available within about 24 hours on our YouTube channel. During the webinar, Alexis will send you the link to that site, as well as the link to our website where we post answers to the questions that you posed at the conclusion of the webinar. For those of you who've participated in previous weeks, you know that we answer as many questions as we can in the time allotted, which we have limited to about 40 minutes in the interest of everyone's time and all the different activities we're performing right now. But we like to answer all the questions, so we provide those to you afterward. You can use the Q&A function on the Zoom application to submit your questions. Our speaker today is Anthony Harris, M.D., M.B.A., M.P.H. Dr. Harris is a board-certified occupational medicine physician. He is WorkCare's Vice President for Onsite Clinical Operations and an Associate Medical Director. Dr. Harris is leading our clinical team for our COVID-19 response and kindly provides these really valuable updates for everyone so we can be more effective in managing the health of our employees. So now I'll turn it over to Dr. Harris. Thank you.
Excellent. Thank you, Karen. Thank you, team, and welcome to everyone. Glad you're able to join us again, hopefully, and if you're new, welcome. We jump right into the topic because we don't have much time and we want to make sure we have enough time to answer questions. So with that being said, we'll get right into the presentation for today. Same format as usual. We'll talk about clinical update, pathology of the disease, and then get into what the picture looks like both globally and in the US for spread of the disease with the epidemiology. Talk about prevention and workforce strategies also. We're going to really focus in on the return to work strategy here and testing as it plays a role. So when we talk about the clinical presentation, what's new? So there is new presentation that is a buzz in the clinical community, particularly amongst dermatologists, and it's called COVID toes. And COVID toes is being seen more in the teenage and the 20-year-olds in the community. And this kind of undergirds the notion that some physicians have had that there are no asymptomatic people in regards to COVID-19. We just haven't uncovered what symptoms they may be having. And so certainly the considerations here is that COVID-19 is creating a response from an immune response perspective that is causing small little lesions to form on the toes and sometimes the hands of these young individuals with COVID-19. There's much ongoing consideration and testing and as well as studies to look specifically and from a causality standpoint, what could be causing these to present. But it's something to note, right, in terms of its knowledge for us to pay attention to these type of pictures and presentations as a sign that the younger individuals that were once considered asymptomatic actually may be presenting this way. These lesions of the form of the toes are caused, in theory, behind it is they're caused by little small emboli. So that's a small little blood clot that kind of clogs up the really small vessels in the hands and feet. So it's not the blood clots that you hear people, particularly in the 50s and 60s or even older, worry about in terms of having a stroke or anything like that. We're not talking about those type of events. We're talking about just really small blood vessels that can be clogged up by the immune response, and these lesions go away on their own. So there's nothing to really worry about from an outcome standpoint. It's just maybe an indication that we can pay attention to for presence of illness in those who once were considered asymptomatic. And so, again, the inflammatory response that occurs, just to zone in on that, is in response to the virus once it builds up in the system and your body's attempt to fight it off. And obviously, we see and know and have talked about the difference between how this virus, COVID-19, affects the younger population versus the older, and its predilection for the older population, 65, 70 and older. And we're seeing the immune response be more robust, if you would, in regards to the younger folk. And that's part of the clinical reasoning behind why they do not present the same as the older population. And so this COVID toes may be a phenomenon of that immune response in the younger. So let's look now at some of the pathology. We'll talk about this again because we have touched on it a couple times in previous talks, but we want to drill down to make sure that everybody's on the same page and understand the testing that's available and what the test significance is. We're getting more and more questions about this, obviously, with the return to work process. And so we want to make sure that we explain this exceedingly well because it is going to be key in regards to how we get people back to work safely. And so we'll spend time on this particular slide so that we can talk about the different types of tests available, right? So RT-PCR is the test that you see with swabbing, the nasal pharynx, so the nose or the back of the mouth. Typically now it's the nose. And if you have a swab that you send off to a lab and they test it, they're testing specifically for pieces of the virus in that sample that they get. We know that 30% of people that undergo this type of test will have COVID-19 but be negative, right? And so we're not using this solely as a means to see who is infected or not, but certainly a positive test does mean you have COVID-19, okay? And so if you have this test done and it's negative, still the clinical picture is relevant for understanding, are you one of these individuals with a false negative test that may still have COVID-19? When we add on the other two tests, IgG and IgM, typically they're done together these days. You can't do them separate, but they both only require a small amount of blood from a pinprick. And we look specifically for IgG and IgM. These are immune components in your body. And let's talk about when they show up, the timing of IgG and IgM. So IgM is first. It shows up in about 7 days, typically for most, after being infected with COVID-19. And your body forms these antibodies, obviously, in response to the virus itself. And if you have this particular immunoglobulin present in your system, it does mean that you have currently have COVID-19, right? And it presents, again, in the early phases of infection. Whereas IgG takes longer to present to be formed in your body. These are the immunoglobulins that linger in your body after the virus is gone. And so if you have a negative IgM and a positive IgE, that may indicate that you are late in the phase of infection and or have had the infection previously, right? If you have IgG and IgM both positive, that means you may still be infectious in nature. And again, when we clarify this for the return to work process, we're looking specifically for those individuals without IgM in their system, okay? Because again, IgM may indicate that you are still infectious in nature. So even to summarize, positive PCR, you have active infection. Positive IgM, you have active infection. Negative IgM, negative PCR, you can be considered potentially in the clear and immune from SARS-CoV-2, right? And immune to COVID-19. Those are the individuals who we want to get back to work right away because they are pragmatically safe from contracting and transmission and transmitting the illness, okay? And that's how this is going to play. These tests will play a key role and are already playing a key role in our return to work process, okay? And like I said today, we're going to focus really poignantly on the return to work process. So let's talk about and just update quickly what's happening globally and what's happening also in the US here in regards to burden of disease. So total confirmed cases with the burden of disease as it existed a couple weeks ago, as it existed last week, and change in color scheme here, but this is the presence of disease per million. And you can see US, Italy, Spain are the hardest hit yet and still and in terms of burden of disease. If we look at total new confirmed cases per million, again, 2 weeks ago, last week, and now this week, still obviously US is leading the way in terms of daily confirmed cases, but we're seeing those other countries, again, hardest hit as well. Italy is kind of on the upswing, if you would, in terms of decreasing number of daily cases, which is a good sign there. If we look at now this new metric we haven't looked at previously is deaths per million, right? And you can see clearly the hardest hit countries as well here, we being the leader in terms of deaths per million. And let's look at total cases briefly here. We clearly we're in the lead with total number of cases well over 500,000 as of a week ago. And if we look at where we are today, we're almost approaching that million mark here, most likely in the coming weeks, right? So we're obviously paying attention to the total number of cases, but we're looking also at the total confirmed cases and the curve that it represents. And this is, again, the doubling time. We've seen this curve before, and we were 2 weeks ago doubling in cases every 2.5 days to 3 days, right? And fortunately, we're continuing to see that curve flatten, and we're doubling now about every 4.5 days. Okay, so obviously that's something that we want to continue to pay attention to, as well as we see some positive signs that the disease burden is lessening in the rate of disease. Another 3-day rolling average, we've looked at this once before in terms of total daily confirmed cases in the US. Obviously, we're heads and tails above other countries, 30,000 cases, right, confirmed on a daily 3-day rolling average. And so we're going to continue to pay attention to the oscillations of this curve. We're looking obviously for a steady downward slope of this curve when as we move forward to indicate that disease burden is dramatically decreasing. Again, looking at total number of confirmed deaths, world versus US. Last week versus this week, we're continuing to increase there, unfortunately. So we were just about 30,000 roughly last week. This week, well over 40,000 cases, and no one's gonna likely catch up to us anytime soon until we have a dramatic flattening of our curve. Total COVID tests, right? We started looking at this metric about 2 weeks ago to look at is testing being done sufficiently to understand the true burden of disease in the US particularly, right? And comparing it abroad. So we are still clearly the #1 tester in aggregate in the world, right? And if we look at where we were a week ago versus where we are now, we still lead that at well over 4 million tests conducted. But if we look at then again, 1,000 per 1,000 people, the number of tests performed, we're still not #1 there. We've been #3 for a while here. This is last week, right? But if we look at this week, we're now #2. So we are increasing our per capita or per 1,000 individuals in terms of our testing. So again, that's an important metric in regards to our ability to understand the burden in the US and to respond appropriately so that we're accurately articulating the risk levels in different regions of the US. If we look at cases, daily cases, or excuse me, daily tests per 1,000 people. So daily tests per 1,000 people, the United States is not #1, Lithuania is actually, but we're #2, okay? So that means, again, if we look at the rate of which we're testing, it's important just to continue to increase this number. And then let's look specifically at how many cases do we, or how many tests do we need to do to find one positive case in the US compared to other nations, all right? So if you're in Vietnam, 650 tests need to be conducted in the population in order to find one case, one confirmed case of COVID. Taiwan, that number is 132 tests for one case of COVID-19. We're at the bottom of the chart here, and that's not necessarily a good thing, right, in terms of prevalence. But United States, every 5.3 tests, there's a positive case of COVID. This then gives us an estimate of, the true burden of disease potentially in the US, because we know we may be underreporting likely the actual burden with asymptomatic individuals, as well as just the sheer number of tests per capita that we have yet to conduct. And that's why, again, we're focusing on increasing the number of tests available so that we have a more accurate picture of burden of disease. So let's quickly look at some of the preventative things that have happened and come out. Obviously, the biggest change or event has been the White House and presenting a plan for reopening the economy, right? And the White House has come out with a phased approach, if you would, for starting up the economic engine, having people come back to the workplace and the whole nine, right? And so let's dig into that and let's look at what specifically should be the response of the workforce, the employer's response in regards to how do we plan for this type of approach that the government is proposing, right? And importantly, we're going to look at their recommendations for social distancing, temperature checks, right? We've been talking about those implementations for quite some time. And we know that there are different levels of employers being able to put this into practice with temperature checks at the door. But again, this is reinforcing that from a federal standpoint. Many states have been enforcing this. We know that some jurisdictions have recommended, right? But some, like Pennsylvania, parts of Michigan, particularly Detroit, are requiring, in some cases like Pennsylvania, for those employers that have a positive case. Detroit says, hey, if you're an employer and you have an essential workforce, everyone has to undergo temperature checks, right? Sanitation is important, disinfect, your plan to disinfect in those high traffic areas, and business travel, right? So when we look at monitoring the workforce for symptoms, we'll focus in on the strategy there so that symptomatic people aren't showing up to work, right? And we'll look at also how do we implement policies and procedures that help with contact tracing when we talk about those who may be positive in the community, from the community exposure, and then how do we prevent that in the workplace. So phase one of what the White House has looked at or suggested is encouraging telework, right? And that's pretty straightforward, no brainer, right? If you can work from home, continue to work from home, even as the economy reopens, because we want to make sure we're still able to practice social distancing in that regard. And then a phased approach to return to work, right? So having, we call it and refer to it as having waves of workers come back to the workplace, and we'll characterize that here in a bit. And then obviously those common areas, we want to make sure the government is saying, hey, make sure that you're able to close those areas and not have a lot of commingling. Those non-essential travelers, still, let's minimize that so that we're not transporting transmission. And then special accommodations for those vulnerable populations, right? And we're going to see that persist, that suggestion persist all the way until the third phase of what the government is proposing. But we're going to focus in a bit here, like I said, on what does that look like to have phase workers and waves of workers. The phase two suggestion here is still encourage telework, Pretty straightforward there. Still keep those common areas closed that exist in the workplace and provide those special accommodations. So if you actually look at what's different, right, they're suggesting that you've already phased in the waves of workers. And most people are back to work at this point, not all, right? But most people, other than those who can continue to telework or telecommute, right? Whereas phase 3, straightforward, unrestricted staffing, everybody kind of goes back to normal. We believe that the new normal still looks differently than the historic normal, right, pre-COVID-19. And we'll talk about that new normal here in a second. So when we consider the different waves of the workforce that should come back in the different phases of the government kind of suggested reopening of the economy, the first wave could look like this, right? In terms of characteristics, those individuals that can clearly practice social distancing based upon their job duties, right? So if I work in a cubicle and I'm not, and I have those obviously barriers on either sides of me, then obviously those physical barriers create an opportunity to decrease transmission. If I am not working in really close proximity because of the nature of my work, then again, that decreases opportunity for transmission, and that those should be strong considerations for how individuals are grouped into that first wave. Those non-vulnerable populations, right? So again, if you have underlying conditions that would predispose you to poor outcomes if you are infected with COVID-19, then likely you should not be part of that first wave. And partnering obviously with your occupational health provider to help uncover and understand from a privacy standpoint who may fall into those waves is certainly something that we are doing with our partners. And then those individuals that have specific productivity gains, right, by working in person, those again should be in that first wave, because we want to make sure as the economy reopens that we have maximized productivity, and those considerations for those workers should help. And then essential work travel is really the first wave as well, right? Those people that need to really travel to get the engine back going should be considered. And then we have this category we're considering immune certified, right? And those are people who have undergone clinical review, appropriate testing, and have immunity been shown and demonstrated objectively to have immunity likely to COVID-19. Those should be grouped in that first wave. And that is because obviously their opportunity to transmit or to contract COVID-19 is low, and they should have that level of freedom to return to the workforce. The second wave, vulnerable population that specifically have access to the proper personal protective equipment, right, masks and other social distancing ability, now can be considered in that second wave, right, where we're opening a greater window to returning to work. And then the optional travel workforce, those who can travel now, not essential to travel, but can travel now to help benefit the business, should be considered in that second wave. And then third wave, yes, we agree that all workers should return to work during that third wave. But again, the new normal does have still processes in place to help uncover and prevent, to help uncover those who may be affected, right, from a health standpoint, not just from COVID, but from other communicable diseases, transmissible diseases in the workplace. And we'll talk about that here in a second. So again, what does a straightforward return to work process look like? Simplistically, daily screening and risk stratification, right? At the end of the day, this becomes part of the return to work process because now we need to have a process that captures risk for the entire population, right? We know that COVID-19 is likely going to be still in the community, right? It's not going away for any time soon. If you recall those curves back from Stanford's publication that we showed earlier last week and the preceding weeks, We know that we're going to be dealing with COVID-19 well into the fall, right? And in particular, what to think about is the impact of the schools reopening, right? And as the schools reopen, we know that the younger population are the asymptomatic carriers disproportionately, and the effect of them returning to an environment where transmission is higher risk, right, because they're back to school, and the potential to see a recrudescence of illness of COVID-19 as a result of that reopening potentially in the fall, right? And so having a strategy in the workplace that is going to be prepared to limit any potential recrudescence or bump in the number of cases from COVID-19 is important to have in place both now as well as into the fall. And the lightest implementation of that, obviously, is a strategy where you're having daily screening performed by all workers through, and this is our belief and our approach that we've been doing for over a month now, through a digital tool, right? And there's numerous companies now offering more and more digital tools for this effect. And then some type of risk stratification in conjunction with your clinicians, your occupational health specialists, so that you're appropriately triaging individuals, not just for COVID-19 particular illness, but any workplace illness. And we believe this will become part of the new norm for the immediate future, so that we can get to the point where most likely until next year, we'll have a vaccine for COVID-19, okay? And if we look at testing and the number of tests that are coming onto the market, last week we looked at the EUA, the Emergency Use Authorization from FDA. The list of approved testing kits is growing. This week, over 41 tests available. Previous week, it was 36. So we know that more and more tests are being reviewed and approved by FDA. Under that EUA authorization. And this is one of the highlights that we're pointing out right now, because this is a test offered by LabCorp. And LabCorp is saying, look, take an online quiz, anyone, right, open to the general population. And if you qualify, we'll send you a kit in the mail. And you swab yourself at home. This is a nasal swab that comes with instructions on how to do it. And you send it off and they'll test it for you, right? And so this type of approach is going to become more ubiquitous, so that more and more people are being tested. We're driving then a more accurate picture of what the burden of disease looks like in the US. And that obviously impacts our return to work strategy, because if you're in an area that continues to be high burdensome from disease, your return to work strategy may be a little different than another region that you operate in, or another business that operates in a region that has a different level of burden, right? But the data from these type of approaches will allow us to, again, paint that picture and then respond accordingly with our return to work strategies. And so again, return to work strategy with regard to the daily screen is essential for capturing all the symptoms. We didn't add the COVID toes to this particular scheme, because again, that's the younger population, the population likely not to be in the workforce. But again, capturing those symptoms that are likely to present in the workforce, aged individuals, is important. And that's the fever screening with thermography, as well as some type of digital solution to capture 100% of the workforce with the daily screen. We talked about this last week. I want to bring it up briefly here again this week, because it does highlight well the areas that should be considered that we mentioned earlier. The return to work process that's recommended from, in this case, CDC guidance is to have social distancing available, and then have the pre-screen, the regular monitoring, and then the protective personal equipment, right? And so you're seeing now more consistency across the board with recommendations from the White House to CDC, as well as how it's aligning with clinical recommendations. Still, we are cautious to recommend that a across the board return to work process that excludes individual case by case determinations is not best practice, right? There will be individuals that are outside the normal window that we see, and this is part of those considerations, right? When we talk about the individual considerations, looking at their particular exposure, looking at their particular onset, duration, and severity of disease, their particular level of infectiousness, right? So some people will only be infectious for 12 days. Some people may be infectious for 21 days. So still that case-by-case determination needs to be a part of the consideration. And so we'll briefly look at this. I presented it in one slide, but I want to dig in just briefly here to show you the different use cases with regard to clinical protocols that we've developed in this case, but are being utilized across the board to help in this return to work process, right? The highest level of risk going down to lowest level starts with those workers that are obviously positive for COVID, tested positive, and they're going to be in a 14-day quarantine more than likely, right? Very rarely would they be any less, like 12 days, 14 days is where they're going to be at. To return to work. If they're exposed to a COVID positive household member, 14 days is historically what's been suggested. We've updated some of these to include 10 to 14 days. And the reason why is if you're asymptomatic, you can, and it's been an appropriate amount of time, oftentimes within that 10-day range, on an individual basis, again, you can start to re-enter the workforce because most people, again, present with symptoms within 7 days after exposure, and the risk of actually presenting after 10 days is decreased. The step lower, if you would, is exposure in terms of risk to work of the community member, right? The household member exposure that is here is higher risk. Studies have shown that. Community exposure, work exposure is a lower risk, again, looking at the criteria for return to work here. And then finally, the lowest risk is those with some symptoms that may be associated with a cold or flu, but not necessarily COVID-19 with no known exposure, right? And so, again, it's important to reiterate, each case will still individually need to be considered for appropriate return to work. That's done in conjunction with your local health provider, your occupational health specialist, and whatnot. That is CDC recommendation, obviously, but it's something that needs to be done in a scalable fashion, right? Accelerating, 6,000 people at one site back to work quickly as the phase 1, 2, and 3 begin to open up across the state to state and whatnot. It needs to be a process that's already in place in conjunction with your clinical provider, and a digital solution is what we strongly believe needs to be a part of that. So I'll stop there. We'll open it up to questions. We can go back and dig into any piece of it that may be of concern for clarifying further. Thank you.
Thank you, Dr. Harris. This is Karen again. We've got a lot of questions as usual, so we'll try to cover as many as we can. Quite a few of them are related to testing and especially the home testing kits, so maybe we could tackle those all together. With home testing kits, what's the timeline? You take a quiz, the kit is mailed to you, you use the kit, you send back and get results. Sounds like days. And is it realistic to believe that the general population can obtain an adequate nasal swab for sampling? How does this technique play into good sample testing? And could you verify what the LabCorp kit tests? It does not measure for IgM and IgG?
Perfect. So yes, we'll work backwards. The LabCorp test that I showed was a nasal swab, so that's not looking for immune components, looking specifically for the genetic material of the virus through real-time PCR. Yes, it looks like the turnaround time, and I don't operate with LabCorp directly, but the turnaround time does seem to be days, with shipping. And the typical turnaround time for real-time PCR is about 2 to 3 days. That's been accelerated with some implementations, such as Abbott Labs, serology testing and whatnot, to hours. But again, with this particular home test, it's likely to take a couple of days. And then in terms of adequate sampling, we know that's an issue even when a trained clinician is involved. We know that's a part of the 30% false negative rate, getting an adequate, because of an inadequate sample. As far as studies have gone to look at the effectiveness of the general population to capture an adequate sample, that is an unknown as far as I have seen. I have not seen any data because these kits have not been available for home use. The only kits under the EUA that's available to actually perform tests, all of them are considered, well, there's only 6 of them that are considered low complexity, right? Low complexity by FDA is considered to be one in which either the general public, home use, or a laboratory that just has what's called CLIA waiver, which is kind of the lowest qualification to perform laboratory tests, can perform the test with reasonable levels of sensitivity and specificity, meaning the results should not differ significantly if it's performed by an individual for home or that CLIA waived laboratory, as opposed to the medium and high level complexity lab tests that require more specialization.
Thank you. A couple questions about taking temperatures. One is a thermometer screening or temperature screening going to be required component as part of a return to work program as you enter the workplace? And would there be a difference between an office setting versus a manufacturing setting? And another question related to taking temperatures is whether if you're in a warm weather or hot weather climate, if that would have any impact. And I just wanted to remind some of the questioners that some of your questions have been answered in previous sessions. For example, Dr. Harris's recommendations on the types of instruments to use for taking temperatures. So you may want to refer back to previous Q&As that are on our website, and then we'll repeat the answers to those questions in our response tomorrow.
Perfect. So what we are prognosticating about in regards to temperature screening, obviously it's recommended by both the White House as well as state governments and local municipalities, right? We believe what that looks like in practice is going to be what is happening today, where individuals are present at the gate, so to speak, screening as workers come in. And that's the current phase, right? Phase 1 of this return to work process. As we get into phase 2 and we have more people showing back up to work and we have less disease in the community, we believe that it's going to be more individuals taking their own temperature versus somebody and boots on the ground standing at the gate, right? And that self-reporting is what can happen still through a digital format like a daily screen, and we're certainly already doing that with many of our employers. That we believe will persist through phase 1, phase 2, and phase 3. Because phase 3, when everybody gets back to work, when everybody starts to get back to school, will be likely when we see a recrudescence of illness. And we want to be ready for a potential bump in the workplace with regard to limiting exposure to others and having still a screening process in place, even if it's self-reported temperature, will be key to helping mitigate that exposure risk. And yes, you know that to address the ambient temperature question, if you live in a hot climate and you're doing temperature monitoring at the site, we know that obviously a environmental component to IR thermography or any kind of surface thermography, skin measured, does play a role in it. So the ideal scenario of having someone in a controlled temperature setting before you take their temperature, or having not just walked fresh out of a 90-degree summer temperature, will be a component that requires attention so that you're not getting false negative readings or false positive readings, so to speak, from thermography, surface thermography.
Okay, so someone just asked, isn't it true that you might not have a fever, but you can still have COVID and vice versa? So is there any real value in taking someone's temperature?
Yes, the value and we've opined about this previously, that we believe, and this is the prevailing notion clinically, is that thermography is essential but not sufficient, right? And so, yes, it is very important to capture somebody with a fever that may not be aware they're fever out. Right. So some people just don't understand that what I'm experiencing is a fever. Either I haven't measured it, or, I'm not attuned to, hey, the night sweats that I had the previous night is a part of that picture. Right. And so capturing the most infectious time, when you're symptomatic and when you're febrile, you're most infectious beginning then, that is something that you want to make sure you have a plan in place to mitigate. Because of the increased risk of transmission. So that's why thermography is essential. It's not sufficient based on, exactly to what the question is getting at, because you have the myriad of other presentations, the GI symptoms, and up to 48% of people, et cetera, that will be missed by those who do not present with a fever. So that's why we have implemented and recommend both types of screening to provide the most comprehensive approach to mitigating risk.
And one last question before we wrap up, and it's related to phase 1 implementation. 2 people are wondering why there's no PPE recommended, and specifically why aren't masks mentioned in phase 1 return to work?
Good question. I mean, so in terms of the phase 1 recommendations by the White House, you will see, as opposed to the recommendations that you see from the White House in phase 1, if you look at CDC recommendations, they do recommend PPE, such as face masks, right? And so those recommendations have not changed. So one would postulate that the recommendation broadly is still, yes, PPE should be worn and provided. Now, as we go from phase 1 into phase 2, then there may be a consideration, right, of, instead of, hey, you have to wear PPE when you're in the workplace, which is certainly what is occurring now, and a lot of, if not most, employers are recommending that across the board. In phase 2, it would be optional potentially, and in phase 3, still yet optional, where we provide the PPEs provided, but not necessarily mandated to be worn. But otherwise, those recommendations, CDC or best practice clinically, I do not believe will be changed anytime soon.
Okay, we're out of time, but we'll be back again next week. Same day, same time for week 7, and we'll be continuing this series until we no longer need to continue the series. So please continue to join us and encourage your colleagues to join us as well. And don't forget to review the Q&A on our website. Alexis just sent the link via the Zoom application. Our website is www.workcare.com. So if you just go to the home page, you can click on our coronavirus resources. And I want to thank Dr. Harris again for his valuable time and these great insights. They're very helpful. So we'll see you again next week.
Thank you all. Stay safe and God bless.